Musculoskeletal ultrasonography often involves imaging a site of injury and comparing it to a corresponding contralateral unaffected side. This side-by-side comparison can help reveal subtle anatomic clues that can lead to a diagnosis. Musculoskeletal ultrasound is also unique in that it heavily relies upon dynamic imaging. One can have the patient actively range his or her joints under real-time ultrasound imaging. This will enable dynamic visualization of tendons, ligaments, and muscles as joints are taken through standard ranges of motion. This can help identify pathologic conditions that otherwise would be difficult to detect using static imaging. As defined earlier, the musculoskeletal system is comprised of muscles, tendons, ligaments, bones, and joints, and associated tissues that move the body and maintain its form. All human tissues that are not bone, cartilage, teeth, nails, hair, or organs are termed soft tissues. Soft tissues include skin, fascia, muscles, tendons, ligaments, fibrous tissue, blood vessels, and nerves. Musculoskeletal sonography requires one to become familiar with the ultrasound appearance of certain tissue types, most of which are categorized as soft tissue. Soft tissue extends from the skin line or epidermis down through the hypodermis, also called the subcutaneous tissue. Then there is the subcutaneous fascial layer seen here, represented by this hyperechoic line. And then below this hyperechoic line, one can see the hypoechoic muscle, and then finally, one can see the very hyperechoic bone cortex. Here's one bony end here. Here's another bony end here. Bone is hard tissue and is very dense and strongly reflects ultrasound waves, thus creating a very hyperechoic image. As a result of bone's density, ultrasound waves do not generally pass through the cortex, and therefore structures deep to bone are not seen. This phenomenon is known as an acoustic shadow, which appears as an anechoic area deep to the bony cortex. Anisotropic artifact is an important and frequently noted imaging artifact that is seen during musculoskeletal sonography. An object is anisotropic if it has properties that differ according to the direction of measurement. Different tissues have variable degrees of anisotropy. Nerves and tendons are quite anisotropic. Tendons are typically the most anisotropic structure visualized during MSK ultrasonography. The arrow in this image points to a tendon. Along most portions of that tendon, the tendon is quite hyperechoic, as one can see its linear striations. But as one gets to the edge of this tendon where the transducer is no longer aligned in a perpendicular orientation over the tendon, a false hypoechogenicity or anisotropic artifact is created. As an ultrasound signal interacts with multiple parallel interfaces, such as those encountered in tendons and ligaments, the signal may be reflected away from the transducer if the angle of inclination is not directly perpendicular to the structure. This creates anisotropic artifact, an apparent area of reduced echogenicity that can be misinterpreted as a pathologic defect in the structure of interest. Anisotropic artifact is most often noted in tendons and ligaments, but can also occur with muscles and nerve imaging. A line in the transducer directly perpendicular to the structure of interest in its long axis view and rocking or heel-toeing the transducer will eliminate the artifact and demonstrate a normal linear fibrillar pattern. In this video clip, one can see these different tissue types. Here's the skin, here's the subcutaneous tissue, here's some muscle seen here, and one can see there's some bone here, this dense hyperechoic cortex. And then, when the muscle gets stretched out in a long axis view, one can see the muscle fibers lengthen themselves out over the screen, whereas the subcutaneous tissue still maintains the same image appearance whether it's viewed in long or short axis. Each of these hard and soft tissues will be discussed in greater detail in a subsequent lesson. In addition, an in-depth discussion of soft tissues is provided in the soft tissue module. A solid understanding of soft tissue sonography is integral to performing MSK sonography. Here is the tendon taken through its range of motion. As the joint is ranged, one can see this tendon demonstrate a linear, fibrillar, homogeneous, and very hyperechoic appearance as it slides upon its plane. The ability to watch a tendon move and assess its function is not possible with any other imaging modality, especially at the patient's bedside. This is a valuable asset. In this clip of the distal forearm, one can see a hyperechoic area with a big shadow behind it. This is what normal bony cortex looks like. Adjacent to that, one can see muscle, which also appears normal. Then, in this video of a proximal phalanx, one sees another segment of bony cortex. Tendon can also be seen with a little bit of anisotropy spanning the length of the screen. One observes the joint cavity in the center of the screen with the bone and its epiphysis on each side. The bone has a very nice, continuous hyperechoic cortical margin. This is a metacarpophalangeal joint, the joint where the finger connects to the hand. One can observe the metacarpal of the hand here and the phalanx from the finger here. The bones can be seen moving in respect to each other. Tendons and ligaments can also be tested dynamically while the provider watches on the screen. After getting the probe right over the position of interest, the operator should scan along the long axis of the bone, observing the bony cortex and appreciating its continuity throughout the length of the structure. Use the unaffected contralateral limb for comparison if required. One of the great things about musculoskeletal ultrasound is that one can typically use the opposite extremity for comparison. So, if one is not certain whether an ultrasound finding represents a pathologic condition, one can use the contralateral extremity as a point of reference. Musculoskeletal ultrasonography is a dynamic exam. One can have the patient actively range his or her joints under real-time ultrasound imaging. This will enable dynamic visualization of entire tendons and muscles as joints are taken through their standard ranges of motion. Finally, recognizing and mitigating anisotropic artifact is critical to performing MSK sonography.
Here is a patient who's had a complete Achilles tendon rupture. One can see here that the tendon is coming along and suddenly there is discontinuity. The calf muscle is quite thickened as well. This is due to the contracted tendon, which is completely disrupted as it's bunching up in the calf area. One observes a complete retraction of the Achilles tendon. So when the joint is taken through a complete range of motion, one can see the tendon completely retract up adjacent to the area of discontinuity. It should be noted that a Baker's cyst is present here. After placing the transducer in the popliteal fossa in the transverse plane with the indicator towards the patient's right, one observes a fluid collection in the posterior popliteal fossa. Again, it's an outpouching of the bursa between the two joints. This is not a joint effusion, it's a superficial process. Here we see this Baker's cyst, and this over here is the gastrocnemius muscle. Now there's no flow detected following power flow Doppler imaging. A simple Baker's cyst needs to be differentiated from something more nefarious, such as a pseudoaneurysm of the popliteal artery. This is a patient who has an embedded foreign body, which actually happens to be a piece of glass within the gastrocnemius muscle. So one can see the muscle fibers of the gastrocnemius coming across here in the long axis, stretching out across the screen. So here's the skin line, and here's this large piece of glass that extends right down into the gastrocnemius muscle. And this is what a calf hematoma looks like. One can make out the superficial gastrocnemius muscle, and then down here where we expect to see soleus, we see all this hypoechoic debris. This is a hematoma. This hypoechoic collection of material is all hematoma formation in the calf. It's quite extensive. Seen here are the calf muscles in the short axis. One can see the subcutaneous soft tissue here, and we can see the gastrocnemius, and then finally the soleus muscle down here, and they are separated by this fascial plane. So from superficial we see some skin line, subcutaneous tissue, gastrocnemius, and moving deep into the soleus. The care provider subsequently performed an ultrasound and found a discontinuity here, right along here. This is her femoral head and femoral neck. This is what a fracture looks like on ultrasound. Here's a 27-year-old male motorcycle accident victim with a right femur deformity. One can see that this distal bony cortex here along the femur, and as we follow it along we can see that it steps off here. This is the fracture line and the step off to the distal fragment seen here. Again, the imaging is performed along the long axis of the bone, screening for any discontinuities in the cortex. This was a 22-year-old female who came in complaining of arm pain after she fell rollerblading, and it's pretty obvious. Here's one portion of her radius, and here's another portion of her radius here, this large step-off deformity. This 78-year-old male fell in the bathroom and came in complaining of chest pain, and the care providers used ultrasonography to easily identify rib fractures. Here's the edge of one rib, and here's the edge of another. This step-off deformity. One can make out these fractures quite easily as long as you get along the long axis of the bone. This 47-year-old female was in a high-speed motor vehicle crash and presented complaining of chest pain. Care providers identified a sternal fracture up here. So this is the edge of the sternum on one edge, and here's the other edge here. And in between the two we can easily see the step-off. Sternal fractures are actually quite easily seen on ultrasound due to their superficial location. Now switching to another joint, this is the olecranon, and one can see the olecranon bursitis. This condition is very common in patients. The anechoic fluid here is very superficial or close to the skin line. Here's the skin line right up here. This is where the transducer is located. It's in a transverse plane right on the edge of the elbow. The bony structures are seen posteriorly. This is all anechoic fluid, and there's a little debris in here, which is common with these olecranon bursitis. These are typically chronic effusions, and one can see that this debris is not actually within any joint space. Rather, it's external to the joint. The bursal fluid is superficial and external to the elbow joint, and no articular bony surfaces are identified in proximity to the fluid. One can actually perform fracture reduction under real-time ultrasound guidance. Here we are bringing this bone end so it comes down to come in contact with this bone end. And we slide it right down into place. And now these two bone ends are lined up. Fracture reduction is again illustrated here. Here's one bone end, and here's the other bone end. Care providers are getting to the other bone end here and trying to bring these two bone ends as close as possible so they line up and have the same angle. Now this is all performed under ultrasound guidance. Try to watch these bone ends come back together. And here's the same patient post-reduction. The bony fracture is reduced, there's much less angulation, and the cortical margins are aligned. The patient is now ready for splinting. Again, here's a normal looking hip joint, but over here we see quite a large effusion, and in fact this patient has a very large hip hemarthrosis. This happens to be non-clotted blood floating around between the femoral head and the acetabulum. This is a patient with an intertrochanteric fracture of their femur. One can see one end of the bone here and then another down here. And in fact, this is the femoral epicondyle starting along here. Here is the step-off. When performing arthrocentesis under ultrasound guidance, the idea is to get the needle between the two articular surfaces of the bone. The transducer is in a sagittal plane with the indicator towards the patient's head just medial of midline. Therefore, this is the proximal tibia seen here, and the needle is inserted just superior to this bone here in this joint effusion. So the needle has to get into this space that is superficial to the bone but deep to this structure running along here, which is, in this case, the superior patellar tendon. This is another example of a joint. This is the metacarpophalangeal joint. One can observe the metacarpal here and the phalanx over here. So again, this is another seagull sign where the joint is. One wing of a seagull here, another wing over here, as we see these two bones articulate with one another. Now this patient, here's this lumbar spine here, and we can make out the psoas muscle here, but adjacent to that psoas is all this hematoma formation here. So this is a psoas hematoma. Basically, it's within the muscle fibers of the psoas. This is psoas, it's kind of over here, then stretching out this way. We can see this large hematoma formation just adjacent to the spine in this psoas hematoma. Now this is an example of another muscle, the psoas muscle. This patient has a particularly very prominent psoas muscle. In fact, the ultrasound operators weren't sure what they were looking for at first, and they had the patient move their leg. As the patient is internally and externally rotating their leg and flexing and extending their leg, they notice that the psoas muscle is changing in shape and size. So this is the spine seen over here. Here's psoas muscle, and they're observing it in various configurations. This is the liver, here is the kidney, seen over here, and again, here's psoas, but this time stretching out in a long axis across the screen. We can see the striae stretching out across the screen here. Here's an example of a comminuted radial fracture. One goes along the bone, and the cortex is very nicely aligned, and then suddenly there's a step-off deformity noted. As the operator continues to scan past this initial cortical defect, there's another step-off here. This comminuted radius fracture is actually broken in several places, and one can see on ultrasound how it's fractured. Here's another example of a distal radius fracture. One can see the angulation of this bone compared to this bone segment up here. So this is the fracture line seen here. And actually distally we see this joint space. Begin by positioning the patient with their back towards you so that you are in a comfortable position to both perform the ultrasound and see the screen. Cover the transducer with plenty of coupling gel. Note the orientation of the probe indicator. It's always going to be to your anatomic left side as you approach the patient posteriorly. Place the probe along the lateral aspect of the arm. The humerus is located in a transverse view or short axis along the upper arm. Adjust the depth as necessary to view the bright white edge followed by the shadow indicating visualization of the humerus. The probe should be moved cephalad up along the humerus, keeping the humerus within view on the monitor. When you reach the superior aspect of the humerus, slide the probe posteriorly along the curved end of the humerus. You're looking for a nice, crisp humeral head seen here, followed by an adjacent bright white structure that represents the glenoid rim seen here. This is the bony segment that articulates with the humerus to form the shoulder joint. Keep the probe in a transverse axis at all times, as this will provide the appropriate view. Obtain a nice view of the humeral head here and the glenoid here on the left. Humeral head and glenoid. When a clean view of the ultrasound is obtained of the shoulder, press the freeze button on the ultrasound screen. This allows the operator to put the probe down because the image is frozen on the screen. You may now drop the calipers by clicking the caliper button. Obtain a tangent line along the humeral head and along the glenoid. click Select, lock in the endpoint, and then get the line as close to parallel as possible. The y-axis of the cursor is used in this example. Once the caliper is well positioned, select the calipers button again. Obtain the tangent line off the glenoid, find the high point of the glenoid, and then work over to get a nice parallel line. That is locked in. Finally, click on the calipers button a third time and measure the distance between the two previously placed line segments. The measurements reveals a step-off distance, in this case, of 0.6 centimeters. If you refer back to this image of the shoulder, the humerus is here on the right and the glenoid is here on the left. Humerus, glenoid. The question is the humerus anterior or posterior to the glenoid fossa? For the purposes of this ultrasound exam, obtained from the patient's back, the closer to the top of the screen or the closer to the patient's skin line is considered more posterior. So the humerus in this situation is more posterior to the glenoid. If you had the reverse orientation such that the humeral head was lower on the screen than the glenoid fossa, then you would have the opposite orientation and it would be anterior. One would normally expect to find the humeral head posterior to the glenoid rim. The step-off distance is the distance of the C-line segment. The C-line represents the distance between the A and B line segments that is tangent to the humerus and tangent to the glenoid rim. This is an example of a shoulder dislocation. This is a right shoulder, but this time one can see the humeral head is actually quite anterior compared to the glenoid. So here's the glenoid, here's the humeral head in an anterior dislocation. The distance is 1.5 centimeters. One can see that this represents posterior and this is anterior. So this humeral head is 1.5 centimeters anteriorly relative to the glenoid rim. Now here's another example of a right shoulder dislocation. So, as we line it up, this is the right shoulder coming posteriorly, so therefore this is the glenoid and this is the humerus. This dot is to the patient's left. So we line up our tangents and this humerus is dislocated 7.2 millimeters anterior to the glenoid. Now, here's a right shoulder, and similar to the previous example, this is going to be the humeral head, and this is the glenoid rim seen over here. The next step is to create the tangents, one from the humeral head, one from the glenoid, and then one measures the distance between these two tangents, which happens to be, in this case, 0.58 centimeters, or 5.8 millimeters. Now here's a normal left shoulder. The operator is now on the other side, the left side, meaning that this is now the humerus, and now this is the glenoid. Remember, this is posterior, and this is anterior. When one draws the tangents from the glenoid and from the humerus, the distance between these two tangents is 6.3 millimeters, which is normal. If a persistently retracted tendon is noted on ultrasonography when a joint is taken through a normal range of motion, this suggests a complete tendon tear. Partial tendon tears do not retract. If a tendon retracts away from the joint cavity when you go through a normal range of motion, this suggests a complete tendon rupture. Such injuries mandate joint immobilization and orthopedic follow-up. Now, when someone has a partial tendon tear, the ultrasound operator should compare the respective sides of the body. The affected side should demonstrate increased tendon width. So, the tendon actually goes from here all the way over to here. and one can see that this part of the tendon is actually fine. It's not torn, but there is this hypoechoic, almost anechoic area seen here. One needs to determine whether this represents focal hemorrhage versus anisotropic artifact. As one changes the orientation of the ultrasound beam, the hypoechoic area persists. It does not go away with changes in ultrasound beam orientation. Therefore, this represents focal hemorrhage. Upon taking the joint through a full range of motion, ultrasonography reveals no tendon retraction, which suggests a partial tendon rupture. Here is a tendon taken through its range of motion. As the joint is ranged, one can see this tendon demonstrate a homogeneous and very hyperechoic appearance as it slides upon its plane. Here's a patient who has a hematoma in his thigh. One observes all this hypoechoic debris seen over here as the hematoma. When we stretch it out into the long axis, we can see this hematoma here stretching out across the screen. This is hypoechoic debris. This is an ulna with a step-off deformity. One cortical defect is noted here, and we can see the next cortical defect noted here. So there are actually two cortical fragments along the ulna in this case. Here, one can see tendinosynovitis in the wrist in the short axis. One can see the tendon seen here in the short axis, and there's a lot of fluid surrounding this tendon seen here and here. There should not be any fluid around this tendon. The tendon should be directly adjacent to its respective tendon sheath. Instead, there is fluid causing thickening of the tendon sheath.